right, guys. So we will keep going. My name is Ben. Along with Ben, you got a bunch of emails from us over the past few months. Thanks for coming and attending our first hybrid conference. Shout out to Matt who helped organize this awesome space for us that are here in person. Um, so this year, last year we actually introduced a primary care exchange lecture where we'd have a colleague from one of the primary care specialties with a sports medicine background that would come in and give a talk. And as many of you know, earlier this winter, we unexpectedly lost a member of our sports medicine community, Sam Dixit, who was a board member at AMSSM. Sam trained at UCLA and spent some time at Cal, Berkeley, and at Johns Hopkins before I met him here at HSS, where he was an associate program director when I was here for fellowship. He was an invaluable friend and mentor to me over the years, as to many people in the community and in this room. He had a positive impact and was a staunch supporter of emergency medicine physicians within sports medicine, such as myself. He was actually supposed to give the lecture this year, the primary care exchange lecture, before his unexpected passing. So in his memory, we'll dedicate this lecture to him moving forward. There's just a couple of pictures throughout the years. All right. So for this year's lecture, we're privileged to have Jeff Bytomski from Duke join us. So Jeff serves as the head medical team physician for Duke Athletics. He was appointed as director of the primary care sports medicine fellowship in the fall of 2019, his second stint, because he also held that role from 2003 to 2011. He serves as a member of the NCAA Concussion Advisory Committee and has been in that role since 2018. He's a past president and fellow of the American Osteopathic Academy of Sports Medicine and is also a fellow of AMSSM. He's the director of the sports concussion program at the James Urbaniak Sports Science Institute and has been on the editorial board for CJSM since 2008. He did his sports medicine fellowship in Duke, finishing in 2002, and has also served as part of the NFLPA Mild Traumatic Brain Injury Committee and was a team physician for USA Basketball. So Jeff will be speaking with us about foot disorders in the athlete. So I will stop sharing here and allow him to take over.
All right, thank you very much. Can you guys hear me okay?
Yep, we can hear you.
See my screen? Thank you. Again, thank you very much for the honor of being the first one. Obviously, it's a very sad reason that I am doing this, but I hope to live up to his memory and honor him with this lecture. So again, appreciate you having me, and we'll go on from here. Again, I just from San Diego State originally, and San Diego area, and went to, as you know, a lot of times in medicine. Did my fellowship here at Duke and stayed on ever since. So my first job has been my last job, which has been kind of fortunate as far as that. We do have, as you guys mentioned in the beginning with fellowship spots, we do have a dedicated EM spot, and that's been really great. And Ben Oshlag was one of our previous fellows in that role. So again, appreciate you having me. I don't have any relevant disclosures. We're going to kind of go through, we'll start with the acute injuries and then move on to some chronic things. And I think hopefully the acute ones more when you guys have your ER hats on, and then even some of the chronic overuse you still see in your ER and ER hats, but also as you guys are in your sports medicine clinics too, to try to kind of go over some common things I think we all see and kind of try to manage. We'll start with the acute foot injuries. Obviously, very common would be second to fourth metatarsal acute fractures, not stress fractures. As far as that, obviously very common. Again, 88% of fractures involving the foot and ankle. Again, we're going to stress the foot ones today versus any ankle issues. Again, female to male ratio 2-to-1. As we know, second to fourth is most common, even in the stress fractures, and then followed by the fifth metatarsal. Not going to talk about first metatarsal. It's very uncommon. And so we're not going to do that or talk about first metatarsal today. Can be indirect or direct trauma. As far as that, I feel like on presentation exam, a lot of times the direct trauma we see in the weight room, they drop a 45 plate on their foot, and that happens with that. We see commonly, but again, it can be also just from implanting. Maybe they have even an underlying stress injury that all of a sudden, breaks through. That can also happen. Or we see like in football sometimes or soccer, those kind of things where another player might step on the other player's foot, and it can happen that way. Obviously, on exam, we have point tenderness usually over that shaft of the which metatarsal it is, but it can kind of be diffuse and reach over into the aligning uh, metatarsals on each side. Usually they'll have marked weight difficulty weight bearing with that, and then also if you're doing any range of motion testing with the distal foot, usually they'll have some pain, or even the midfoot if we're looking for also those Franck injuries. That would be the one area towards the first and second metatarsal. We'll go over here in a few slides. With that, usually they're neurovascularly intact. Usually X-ray is sufficient, right? So we can obtain, you want, if they can weight bear on it, really try to do bilateral weight-bearing views to assess the Lisfranc joint while you're looking for these. So that would really be helpful. And we're also looking for displacement and shortening, because that will kind of guide us, do we need to get orthopedic referral or not, or can we treat these things conservatively, in first non-weight bearing, then in a boot. Usually CT or MRI is reserved again if we're looking for other concomitant injuries, or if we're thinking any surgical management. CT is helpful for the surgeons, or also MRI is going to help us a lot more with some of those Franck injuries as well. So usually treatments for these things, especially if it's just a single metatarsal, you can be treated if, we have all the boots or even cast shoe for 6 weeks. I don't usually cast many of these. You would save casting for if it was more multiple metatarsals, or if there's something where it might be you're considering surgical and we want to try to keep them out of the OR, we would do it that way as far as that. And so it depends as far as weight bearing for me. Most of the times, I think they feel more comfortable in the first couple of weeks non-weight bearing, but it just depends. Maybe if it's a single, third metatarsal or something, they might be able to get away with weight bearing in the boot with that. And I usually will tell them to go online and get if you've seen these things, even up. So where you can, it's a little, thing that goes on the outside of their shoe that kind of evens up their gait. Because you'll start to notice they'll have, contralateral hip pain and some other things going on with their gait change that way. So if you get that even up, it's much easier for them to walk, and they might they'll be able to return and play a little quicker because they won't have some compensatory things from the boot. As far as that, some of the things we're looking for operation or operative management would be greater angulation 10 degrees, displacement 3 to 4 millimeters, and again, multiple fractures. I would say most multiple ones I would consult at least ortho and, hey, decide, can we take care of this, or do they want to see it, and then getting a serial follow-up on our x-rays with that. Again, some other operative indications on the head and neck area, again, not just in mid shaft, but as you go towards a little more distal head and neck, are similar. And again, if they have more than 50% translation or more angulation than 20 degrees, or again, if you have a couple metatarsals, I would get ortho folks involved just to get their sign off on that. Base fractures, again, I would definitely assess, especially the second or third, assess for also concomitant Lisfranc injuries with that. But if they also are non-displaced, they can also still be treated conservatively. Here's just some of the typical things you can kind of do operatively. There's many ways. Sometimes we'll put screws or plates on them too, but a lot of times we can pin it, and it'll keep it thick, because you do have some ligaments on each side, and some things that'll kind of keep it stable, even with just stabilizing in this regard. Let's move on to those Franck injuries. So again, named after Jacques Lefranc. Again, French surgeon, gynecologist, and did everything there, I guess, back in the day. Again, in Napoleonic Wars, they also say, at least some of the things I've read too, is because when they would kind of fall off or out of the horse stirrups and things, sometimes they would get these injuries, and that's where he was first seeing these. And as he was doing some amputations to these joints for the management of the gangrene back then. So kind of interesting history with that. But today, in this day and age, we almost always see it. Obviously, probably mainly in football players, right? Where somebody's, and I'll show a picture next one, where they're planted, and then somebody kind of falls on the back of their foot with their forefoot plantar flexed. With that, and like I said, I think I've seen it more in football players than anything else. Again, and just in one study, I'm not saying about the ED folks, but let's say can be missed, or if you're not thinking about it, and with that, and sometimes you also, I think part of this is maybe in the ED, just because you might not get weight bearing views if they can't, it might not be a common protocol to do weight bearing views. So maybe in trying to get that bilateral weight bearing view, I still feel like, even if there's close follow up, immobilize them and get, as long as they have close follow up and referral, it's not a big deal as far as, if there's not weight bearing views to get in the ER. This is just kind of some of the anatomy. Again, you have the multiple ligaments going across from your first metatarsal C1 there, and going across to 2 and 3. And so this is what we're looking for. If any of these ligaments are torn, you'll have your classification scheme underneath here that will help us guide, again, conservative versus operative management. So the stable ones, type 1 and 2, where there's less than 2 millimeters of displacement or without any avulsion fractures, you'll be able to stably treat these. Again, I would still kind of any Lefranc injury, I go over at least, here with Dr. Amendola, our foot and ankle specialist here, and kind of run it by him and let him make the call. As far as that, most of the time, if they're stable like this, you can either cast and immobilize, or again, it's pretty easy to put a screw across there too, surgically. Also, depending on return to play, level of the athlete, comorbidities, those kind of things. If it's displaced more than 2 millimeters, we have a fracture or other things going on, then those all need to be fixed as far as that goes. Again, here's the mechanism. You can kind of see where somebody falling on a plantar flex foot as far as that. So on the exam, again, you're going to see pain at that TMT, first TMT joint, even over the second, third sometimes. Usually have marked swelling I've seen, especially if it's the next day, for instance, on an on-field assessment. It's going to be pretty swollen in that midfoot. Plantar ecchymosis, at least in some of the articles I was reading for this, is pathognomonic. So if you do see that, you really need to be aware of looking for those Franck injury. Again, they all have difficulty weight bearing, which obviously isn't sensitive for this, but and then pain with movement, with they're either gonna, if you either kind of twist the midfoot or try to kind of piano key that first metatarsal, they're gonna have marked pain with that as well. So X-ray is usually first line, like I said, if you can get the AP lateral oblique and also weight bearing if possible, so you can compare side to side, and I'll show that here in a second. Again, sensitivity, specificity there's pretty good, really, for radiographs with that. CT, obviously, for bony anatomy, and the MRI is for looking also for the concomitant ligament injuries without avulsion fracture. If there's a avulsion fracture, see there, obviously CT would be maybe a little better. I tend to go MRI first, just no radiation, at least in the outpatient setting. For inpatient, CT might be easier for you guys in the ER as well with that, but I know you can get both. Again, here showing that kind of widening at that TMT, first TMT joint. You can see again, here's the another one. And then on the last one there, we can see the button fixation with that. You can see that brings it nicely together and brings good fixation. Here's just some other operative ways. And again, those other ones also have concomitant fractures with this. So instead of just being able to do that nice little button there, then sometimes you'll have to do some more operative care. Here's just I know it's a little busy, but treatment protocol for suspected injury, again, kind of has just a kind of picture of what we talked about. Again, looking at exam and then initial radiographs. And then again, if there's fracture or not, get CT. Again, do you feel like there's more than 2 millimeter diastasis, then we should get some further imaging and then refer for possible surgical management. And we kind of just a kind of summary of what we just talked about in the last few slides. We'll move on to Jones fractures. So now moving on to that fifth metatarsal, again described by a lot of things here. A few of them here today, described by folks back in the day there, Sir Robert Jones. Again, it's very important it's very specific for a Jones fracture versus I think some people kind of lump proximal fifth metatarsal fractures all together, but the Jones is a very specific one at that 1.5 centimeter, and I'll show a picture here in a second. Usually acute injury, but we have seen a lot, especially in some of our basketball guys, where they have some underlying stress injury. Even lacrosse and football, I'd say those are the top three sports, an occasional soccer player and things that we've seen these in. Again, usually indirect large adduction force applied to the forefoot. Again, not usually a direct, stepping on it or that. So again, why are these important and why is it different and why doesn't it heal? And we need to do more usually surgical management on these than you would think. Would be again, there's a vascular watershed area, retrograde blood flow, which I'll show a picture here in a second. And again, this just as being a DO and AT still, the rule of the artery is supreme, and things don't heal very well, just like diabetics and other things. If there's not good blood flow to the area, these are areas where we seem to cause problems, just like navicular and those kind of things too. So here's the anatomy of the Jones fracture blood supply. Again, you can see where the fracture site is there, and you can see that nutrient artery has that retrograde blood flow. So again, that gets cut with the fracture, and so there's not a good blood supply to the area, and that's why there's less healing potential that occurs with these. So here's kind of a nice graphic of, again, proximal fifth metatarsal fractures. So again, you get everywhere from the os And then especially the apophysis there, that normal 10 to 16 years in that green area, really important because I think some folks I've seen, or I've got some referrals occasionally from primary care folks where they feel that was an acute fracture or something when that can be just a normal variant in kids compared to those in the purple area, the avulsion fractures to that tuberosity, those are managed very easily, conservatively, just as you would almost like an ankle sprain, kind of treat that with short-term boot and increased activity is tolerated versus that Jones fracture in the red area there, where we really need to have better imaging and also consider fixation with that, especially in higher level athletes. They're always going to get screw fixation with that. And then you'll have just proximal to that again. Sometimes when you'll see that, you'll see the thickening, cortical thickening in that more proximal to mid shaft of stress fractures. I had a fracture through that mid shaft when I was in med school. Actually, just stepped on another player. They're trying to take a charge, of course, in basketball, and then I stepped on their foot and broke my fifth metatarsal. Of course, they called that a Jones fracture. I didn't know any better at the time, but now I know that it was not a Jones fracture. It was just more of it was a spiral, a mid-shaft fracture. So anyway, so it's very important to know that nomenclature and where the fracture is. Again, they're going to have tenderness over there. They will have swelling, difficulty weight bearing, and then some weakness on perineal testing as the perineal brevis attaches near there and a longus going underneath there. Here's the X-ray views of it again. You can see a lot of times, even from the one on the left there, looks more acute compared to the one on the top right there. You can see that little more cortical thickening that they have, so they might have some early stress component with that. And then on the lateral, you'll be able to see it as well with that. So again, treatment is usually surgical fixation. You can, um, I've had patients, maybe some older patients, mid 40s, 50s that do this, and maybe the poor surgical candidates from other comorbidities. They're not a high level athlete. They don't want surgery, those kind of things. I have treated a few of those non-operatively. These are one of the ones where I will actually cast them, not do a boot, and be strict non-weight bearing for minimum 4 to 6 weeks. With that, you have to be really diligent about, not having any motion if you're going to try to treat these non-surgically because of that blood supply. Now with their screw fixation, they are doing some orthobiologics or BMAX grafting in there, bone grafting sometimes with that to try to get better healing because there is still a failure rate sometimes, even with early surgical management. And again, it's very important to have a kind of a experienced surgeon that can put it in correctly with the right screw and those things. And so again, if you get the appropriate thing, they can do very well. Usually we'll do, if they do have surgery, non-weight bearing, 2 to 4 weeks, some physical therapy to work on some passive range of motion, continue, core work. They can do a stationary bike at 4 weeks and then progress to a supportive shoe with an orthotic at 8 weeks. And that orthotic's just trying to load that area a little bit. Return to sport, for most could be 4 to 6. You can get them back sooner. And obviously with some of the higher level pro athletes and things, you'll see they will get back a little sooner. They will usually get it when we would do the same with our guys here. We get a CT scan to see if there is bony bridging and healing. And if they're pain free and their shows healing, that's when you can start their return to play and get them back probably sooner than especially that 6 months. Move on to turf toe, plantar plate injuries. Again, that's it. Now we're the first MTP joint. Again, same kind of similar thing, right? Where they're cutting, planting. Somebody can fall on the back of their foot. Again, you can see this a lot in soccer. Obviously, footballs were probably first discussed with that, but you can see it in other any sports that are doing cutting, pivoting type activity. Some of the risk factors, again, if they've had prior injury, hallux rigidus, artificial turf, where it became, when artificial turf started coming around in the early 70s, mid 70s, that's where they kind of coined the term with the turf toe as far as that. Also, you've seen, if the footwear is really too flexible or not enough support over that first metatarsal area, that's where you can get kind of more increased flexion through there and increased risk for injury with that, as long as foot pronation. So kind of similar injury to those Franck injuries, again, with that. So just again, when you're looking at that also, depending on, again, where they tender, is it more first MTP or more midfoot with that? And so you're going to look at that same kind of area and same mechanism. And you're going to have pain MTP, and it can be, again, is it the plantar surface or dorsal surface? I've seen it's just kind of sometimes it's all over the place, right? The whole thing hurts. Maybe somewhere medially with collateral ligaments around there. Again, sesamoid pain, do they have sesamoid fracture with it? with that, and they'll have pain with passive range of motion, swelling, ecchymosis in the area. Again, same kind of thing, difficulty weight bearing. And then you have this Lockman's testing, which, some people, until I kind of maybe did my fellowship and got into practice, started to look at this. So it's true, it's kind of similar to the knee, where again, where you're doing instead of between the tibia and fibula, tibia and femur, excuse me, that, you're going to take that first MTP with your fingers and kind of move it up and down. Same kind of thing. Take the other side, compare what feels normal to them. They have increased laxity. Is there an endpoint? Those kind of things can kind of just lead you, hey, do we need to get more imaging here if that really feels like they have more translation when you're doing this test? And here's some of the classifications of that. Again, if you're getting that migration or on X-ray, to show in a second, if you get some sesamoid migration on the X-ray, that's also showing that you could have a plantar plate injury, and so you really need to get further imaging of that. And so here, X-ray again, looking for that fractures or sesamoid migration, which you can see. Also, a lot of people obviously have bipartite sesamoids with that, and so you can see sometimes it'll just have some proximal migration of that sesamoid with some of that. And then also, I'll show you some ultrasound pictures here next that you can also consider looking at to see if there's an injury as well. It's kind of a nice point of care evaluation, right? You're on the road, got your V-scan or whatever else in your backpack, and you can kind of put it on there and get a quick evaluation there. And then MRI would be also more definitive, looking for other injuries as well. Here's a nice picture of ultrasound. So you can see on the left one there's your flexor tendon going up across there, and then your plantar plate is the distal DPP, and then the proximal PPP, so you can get your bearings that way. And so you're looking right underneath the tendon there with that. And then on the right view there, then you're just looking at the short axis view, same thing there. So you can kind of say, hey, is there any injury, swelling? Look at the sesamoids with that. And then you can also see, so here's a tear, that plantar plate underneath the tendon. So you're able to see with ultrasound that way on long axis. Here's an MRI saying similar thing, findings there where you can see that. So treatment of these things, so again, they're going to grade them. 1, 2, and 3, and again, grade 1, not really even not weight bearing. They're probably just a little bit sore, but then you can just put one of those carbon fiber inserts or stiffer soled shoes. Athletic trainer can also tape it so it's doesn't get as much flexion. With that, you can also do a post-op shoe or boot if you need to, if they're a little sore just for a few days. And again, even back 6 to 8, I would say they're probably back sooner than that, but that was just some of the papers reading through this. But it depends, especially with taping and some rehab and other things. They usually come back a little sooner than that. Again, they can start low impact activities whenever they feel, pain-free, something that's not just stressing that plantar flexion. So biking, elliptical, aquatic therapy, and then again, return is tolerated as they go. Grade 2, at least a couple of weeks, and I said it even takes. I think grade 2s are going to be a little more sore, and you're gonna, so for planning for coaches and everybody else, it's probably going to be 6 to 8 weeks till they're really like full go, not feeling any problems with this, but it could be sooner. Again, same thing with our PTs, working on range of motion, cross training, gradual weight bearing, and again, doing the taping and stiff insole. Or if you have also access to formal orthotics, that they can get a personal orthotic, that would be something you can consider as well. And then grade 3 is a complete rupture. So these are, much different animal, just like those Frank and the other ones where we really need to, usually operate on them. You had one of our basketball guys here about a decade ago that had one of these and only played a few games for us and missed the rest of the season. He did treat it non-operatively, but again, it was it was about 6 months probably with that, and tons of re-imaging. Again, non-weight bearing initially, and then slow progression back to activity. So it was very, very slow for everybody with that. And so again, things you look for at the return to play is 50 degrees of painless dorsiflexion. And again, painless, they're walking, they're going to be able to cut, jump, do those things. Again, those two are usually going to be taped or have an orthotic when they do return to play to prevent kind of more forced dorsiflexion more than that. Surgical indications, again, either failed operative management or if they have a large avulsion, migration, diastasis, loose body. Again, if it's a complete rupture and you're getting some of these things, they're probably going to do better operative than non-operative. So let's see, I'll move over to the chronic things here, and we'll kind of do this quick because we're about out of time here with that. Marcher fractures, again, Most common, second and third, count for about 90% of fractures and running frequency. There's some intrinsic factors, which we all kind of know about, especially red S and female athlete and those kind of things. Then you got the intrinsic things of most commonly training errors. Out of all those huge things, usually training errors and training volume. Again, insidious onset and will progress and pain will localize and with walking or standing. And then exam their tender over the metatarsal and again trying to figure that. Also just assess navicular and navicular stress fractures are missed quite commonly with that. And so that's also something to consider with that. And so really poke over that bone too if they're more tender towards the ankle. They usually have some swelling as it progresses. And you look at single leg hop tuning fork is limited value. There's always some studies looking at that, but really not, looking especially tibia and things like that, tuning fork with that. And then here's, imaging. I just like to put this up just so you can go, especially I took out the middle column, which is bone scans, which most of us don't do anymore, but looking for radiographic findings versus also the MRI findings. And why it's important is that one on the right there is just your expected kind of return to play. So that for coaches and athlete and all that kind of stuff, you can kind of, obviously there's a wide range, right? But depending on the other factors, red S, other things and training and foot mechanics, all those kind of things. But it's something you can really help you guide, maybe at least initially, hey, this is how long you're probably going to be out. And so I think that's been helpful as far as that. And again, so we start with a boot, non-weight bearing, cross training, no NSAIDs, those things, and then look at other risk factors, and then phase two, returning and go from there. So again, I'll probably the last two will end for time, but I left it on there just so you have it, plantar fasciitis and also Morton's neuroma, but you can have those to look at later. I just want to stay on time for everybody as far as that. So if there's anything other questions or in the chat, stop sharing there.
Any questions for Dr. Bytomski? Anything in the chat? No. All right, that was great, Jeff. Thanks so much. That's bread and butter, foot and ankle. I mean, that is a very high yield lecture. I think all of us could use a refresher on that. So thanks so much for taking the time to do that.